Welcome, everybody. I'm Waqas Haque, one of the Oncology Fellows at the University of Chicago. Joining us on our podcast episode is Dr. Mohammad Jahanzeb, who also goes by MJ. Welcome, MJ.
Thank you so much for having me, Waqas.
And, really glad to have you today on our episode and our podcast. We're going to talk a little bit about some of the things you're working on. I know you've had a really distinguished and varied career in oncology, and we're going to kind of focus on one of your latest gigs with PrecisCa. So first, tell us, as a founder of PrecisCa, what kind of, inspired you to create this platform that helps create and combine sort of video education, content creation, and second opinions for patients in oncology?
Well, thank you so much. Again, and great question. I actually had this idea of having experts convene to discuss complex cases because I was a speaker for a series of meetings called Challenging Cases. And they were really for pharma marketing research of how private practitioners think. And there would be about 100 to 120 oncologists in the room, and they would invite breast specialists for a breast meeting, lung specialists for a lung meeting, 4 or 5 specialists, all day long present 25 cases, 15 minutes each, as if you were in a clinic with 5 or 7 experts.
Right.
And there was audience response system because it was market research, and they would ask a question with 5 treatment options. People would vote, and then at the end of the speaker presenting their views and data, they would ask the same question again and see who can move the opinion, in what direction the opinion moves, what is the current prevailing opinion, etc. And I, being a speaker waiting for my turn, would sit there and see this and wonder what could be if these were real cases. How much service would that be to those complex cases? But I didn't have the means to start something like that. And when the pandemic hit, one of my friends who was looking for investment ideas to start a new company in healthcare space, and he's an engineer and management consultant, I gave him this idea and he said, "This is exciting. Let's start tomorrow." So it was a little over 4 years ago, and here we are with 1,800 videos and 400 plus cases. The rest are mini lecturettes. So it's really been a great journey. I give credit to him for funding it.
Yeah. And so you touched on sort of the content creation as one aspect and also the second opinions. First is kind of dive a little deeper about the medical education aspect. Medical education has changed so much over the years and decades. The first data book for medical school used to be a small little booklet, maybe 30, 40 years ago. Now it's 1,000 pages. And also the way that people learn in medical school and training has also changed. A lot of people are using more digital platforms, more videos. And I know with PrecisCa's online, video repository, there's over 1,500, almost 1,700 videos now. How do you kind of see sort of this digital library kind of transforming how oncologists and trainees think about medical education and keeping up with different knowledge?
Well, first and foremost, you had to be somewhere to learn. And now with asynchronous learning, because that's what we are asynchronous peer-to-peer learning. People can listen to our audio while they're driving. They can watch the video if they're on ground somewhere, but they choose the time. It can be 2 a.m., it can be middle of the day. So that's the biggest asset that we have. Is the other is cases are complex and real. They're not made up cases for some theoretical polling. They are real cases, and discussions are among real experts who are from various top institutions. So you not only get a multidisciplinary view, but a multi-institutional view. As you know, institutions have their biases. So we have gotten out of the institutions, and that way patient gets the most diverse, most comprehensive opinion. And cases are anonymized, and it's peer-to-peer education. So there's no practice of medicine going on, and there's no violation of HIPAA going on because they're anonymized. I think it works well.
Yeah. And you kind of touched on a couple of things there. The asynchronous learning, where the lecturer doesn't have to be in the same classroom as the person learning at the same time, and you also talk about multi-institutional view about sort of combining views from different perspectives and practices. Can you also comment a little bit maybe on how this bridges the gap between community practice and academic oncology?
Yes. So 85% of practice goes on in the community, and there the real-time dialogue among experts happens sometimes in organized hospitals that have tumor boards, but a lot of people in rural America don't have the luxury of having tumor boards. So
Right.
this is basically a great equalizer. It democratizes the process, not
Hmm.
only in the United States, but around the planet. Anyone can send a complex case to
Right.
PrecisCa, and they could be in any country for as long as they understand English. And we are looking at other languages, by the way, and now
Right.
platforms like YouTube can do translation, so you don't need to have a separate translation feature. So we really like the idea that people don't have to live in Houston or Boston or New York to go to a great institution to get an opinion. We just need to come to one clinic called Zoom, and our
Yeah.
experts are in that clinic, Zoom, and that's why the idea emerged during the pandemic when everybody was on Zoom.
So can you just talk a little bit about how the platform works for the second opinion technology and kind of how you take patients or providers through that?
Yeah, that's a great question. And main technology per se is Zoom.
Mm-hmm.
And we bring all the doctors and patients to Zoom, and that's how the idea emerged during the pandemic.
Mm-hmm.
But we don't accept hundreds of pages of record um, and send them to the faculty. We ask that they fill out our case report form, and we have a case report form for every tumor type that we deal with, which is the major 5 areas: lung, breast, GI, GU, malignant hematology. And
Mm-hmm.
that case report form may have 36 or 40 elements of information that need to be filled out, which is all we need to make a decision. And then our nurses, nurse practitioners, fellows summarize that information on 5 to 7 PowerPoint slides. And that's what we present to the faculty, like you are presenting in a tumor board in an academic institution. And they opine based on those slides. And slide has the case ID number of the
Mm-hmm.
patient so that patients can verify that this is not a generic
Right.
advice. This is very granular and very specific to their case.
Got it. Got it. Okay. Yeah. That makes sense. And in terms of the sort of the expert panel discussion, um, there's of course sort of this merging between technology and startups and sort of as an oncologist yourself, what kind of challenges have you faced creating a technology focused company, and what kind of advice do you have for other entrepreneurial oncologists?
Of course, the biggest challenge always is funding. So I've been extremely fortunate to have a single investor, single person who had the resources and believed in the idea. So that's number one. Then, of course, there were challenges on how to get around HIPAA law, and we came up with anonymization, case number, case ID, and then how to get around practice of medicine was a big hurdle. How can we convince faculty that's clinical at major institutions where they're afraid of their legal departments,
Mm-hmm.
blaming them for providing their expertise for patient care outside the walls of the institution? So we removed them 2 steps from the patient
Mm-hmm.
because the provider sent the case. That's one step. And the other is we don't allow the provider to come on the Zoom call.
Mm-hmm.
We PrecisCa presents the case. So there are 2 steps removed, and there's disclaimers before and after, and they are totally safe. That's why we had no problem recruiting faculty, and they feel very comfortable. The
Got
third challenge was, what if we are hugely successful? What if we get 1,000 breast cancer cases?
it. Mm-hmm.
So then we came up with a system of bucketing, which is now we are pending a patent on it, where uh, we started thinking linearly and in a manner that our diagnosis keeps going in forks. You start with breast cancer and take a fork into metastatic or not. And within
Mm-hmm.
not metastatic, you are either ER positive or negative, or
Yeah.
you're either HER2 positive or not, you're triple negative or not. And then you could be a rare subtype like metaplastic, you could be mucinous. Once you look at all the scenarios, it adds up to about 28. So you cannot give me a case that doesn't fit in any of the 28 buckets. You can't
Mm-hmm.
give me a case that fits in 2 buckets. So with such clean separation of 28 buckets, if we get 1,000 cases, we'll still have no more than 28 scenarios. And if, let's say, in a bucket you have 10 cases, you've discussed the mainstream case, the surgeon speaks first, then the radonc, then the medonc, then
Okay.
radiologist may something, and then after 15 minutes of recording of that mainstream scenario,
Yeah.
then the remaining 9 cases can have 30 seconds of a twist. So you
Yeah.
dispense with 10 cases in about 20 minutes. So that's our system of bucketing.
Wow, no, that's pretty cool. But if you do one bucket a day, I don't think you can become an oncologist in 4 weeks, right? So I think the 30-second
Yeah.
twist is important, and of course, you're getting expertise from different specialists. So
Yes.
that's a really nice way of kind of sort of just like synthesizing into a few key areas and allowing for complexity to emerge out of that.
Yes.
And then in terms of the sort of the virtual second opinions that you all have done so far, the 400 cases, is it usually people looking to get into a clinical trial? Is it asking, is this the right treatment? Is it treatment escalation? What are some general insights you have from the cases you've done so far?
Well, most often it's various treatment options, and it could be somebody going from fifth to sixth line therapy because after 5 lines of therapy, their oncologist said, now it's time to go to hospice. We have nothing left
Yeah,
for you. And it's amazing that our faculty comes up with not just one, but multiple additional options for that patient.
yeah,
And that's priceless. So that's the biggest lesson we have learned because most cases are advanced. In early cases, what we learn is how valuable multidisciplinary input is, where there is a need for radiation, need for surgery, need for medical oncology, talking about systemic therapy, but the way they nuance it and the way the sequence changes, that in this one, surgery needs to be first for the following reasons. In this one, surgery should be after neoadjuvant, otherwise it'll be shortchanging the patient. And similarly, radiation has to tell us what subtype of radiation, whether it should be brachytherapy, whether it be whole breast, whether it will be comprehensive involving various nodal regions, whether this patient needs radiation despite mastectomy, etc. So it's very nuanced. It gets into the weeds of knowledge that somebody seeing 38 different cancers a day doesn't get into. Yes.
right, right. Yeah, no, no, thanks for sharing that. And then final question, you're obviously sort of in many different spaces, you're wearing different hats, sort of the business hat and sort of emerging into technology and medical education, and of course, the practice of oncology. So, what's your information diet like? What do you read? What do you keep up with? How do you kind of keep track of everything and keep learning?
Well, learning is an attitude, as you know. You are born curious, or you have very limited curiosity.
Mm.
I always had curiosity. I've always been a bookworm,
Yeah,
and to keep my sanity, because we are all forced to read medical literature to stay up. To keep my sanity, I try to read an equal amount of non-medical literature. It can either be books on history or self-improvement, psychology, or in Urdu, which is my second language before English, I read poetry and humor in Urdu. So that's why the books you see behind me appear to be in two different languages.
very, very nice. And I'll just sort of wrap up by saying that I know that PrecisCa also offers the Fellows Conference, and I was sort of fortunate and happy to be able to attend the conference in Miami earlier this month, where I was able to connect with other fellows and kind of go through a day learning about sort of different topics in medical oncology, including about clinical trials and the role of AI, and also doing some educational cases. So thanks for helping facilitate that as well.
No, I'm glad you liked it. I'm glad you made it. It was great having you, even if part of the meeting, because you're so busy in so many things yourself.
Yeah. And yeah, for other fellows and other trainees, definitely look up their website. They have a lot of medical education stuff and also some opportunity for fellows like the conference as well. But yeah, thanks
Great.
so much, Andre, for joining today. And thanks for answering all the questions, and all the best with all the work you're doing.
Thank you so much. It was a pleasure.